Hello everyone. Today we will read about the clavicle, which is the part of osteology from the book Vishram Singh. So let's start. Clavicle. The clavicle is a Latin term which means key, or the collarbone is a long bone with a slight S-shaped curve. It is located horizontally on the anterior aspect of the body at the junction of the root of the neck and the trunk. It articulates medially with the sternum and first rib and laterally with the acromion process of the scapula. It is subcutaneous and hence it can be palpated through its entire extent. It is the only bony attachment between trunk and the upper limb. So remember only. Where the only comes, it becomes important. So repeating again, it is the only bony attachment between the trunk and the upper limb. Functions. The functions of the clavicle are as follow. First, it acts as a strut for holding the upper limb far from the trunk so that it can be moved freely. It allows free swing of the upper limb for various prehensile acts such as holding and catching. Second, it transmits force from the upper limb to the axial skeleton sternum. So it acts as a medium for transmission of the force from the upper limb to the axial part of the body. Third, it provides an area for attachment of muscles. Peculiarities. Read it and listen it very carefully because in Viva this is often asked. So, peculiarities. The peculiar features of the clavicle are as follow. First, it is the only long bone which lies horizontally. It is modified in the new textbook. It has no medullary cavity in its medial 2/3. Lateral 1/3 has medullary cavity. Third, it is the subcutaneous throughout its extent. It is the first bone to start ossify between the 5th and 6th week of intrauterine life and last bone to complete its ossification at 25 years of age. It is the only long bone that ossifies by two primary centers. It is the only long bone that ossifies in the membrane except for its medial end which ossifies in the cartilage. Membranocartilaginous ossification. Long bone ossifies in the cartilage. 7th, it may be pierced through and through by cutaneous nerve. Intermediate supraclavicular nerve. This 7th point is generally missed by students while reading. So repeating again, it is the bone which may be pierced through and through by cutaneous nerves. The nerve is intermediate supraclavicular nerve. Remember the name. Intermediate supraclavicular nerve. Now parts. The clavicle consists of three parts, two ends, medial and lateral, and a shaft. Ends. First, the lateral acromial end is flattened above downward and articulate with the medial margin of acromion process. Second, the medial or sternal end is enlarged and quadrilateral. It articulates with the clavicular notch of the manubrium sterni. Now shaft. Shaft is curved. The medial 2/3 is round and convex forward, and its lateral 1/3 is flattened and concave forward. So see it visually first. Hold the clavicle in your hand and try to observe it. Then listen to this video to understand it better. So the inferior surface of the shaft possesses a small longitudinal groove in its middle third. Anatomical position and site determination. So whenever you give viva, you have to first speak out the side determination of any of the bone. The side of the clavicle can be determined by holding the bone horizontally in such a way that its flattened end is on the lateral side and its enlarged quadrilateral end is on the medial side. The convexity of its medial two-thirds and the concavity of its lateral one-third faces forward with longitudinal groove in the middle third of the shaft facing inferiorly. Features and attachment. So we need to see figure 2.2 and 2.3 first. So figure 2.2, which figure A has the acromion process, acromion end and sternal end. See, this is the anterior, posterior, medial and lateral side. So anteriorly it is concave and in the middle, medial two-third and convex in the medial two-third and concave in the lateral one-third. And this is the superior aspect, and inferior aspect we have just now read. There is a shaft or a groove, shaft which has a groove in its middle one-third inferiorly, which is referred as subclavian groove. It is important point of side determination. Other features of inferior aspect are rough impression of costoclavicular ligament, nutrient foramen in the subclavian groove, conoid tubercle and trapezoid ridge. Here we are considering this as the posterior side, this as the anterior side, this as the lateral and this as the medial aspect. Read this carefully to clear your confusions while reading the diagram. So let's now see the lateral end or acromial end. It is flattened above downward, has an oval facet on this end which articulates with the facet on the medial margin of acromion process to form the acromioclavicular joint. The lateral end provides attachment to the fibrous capsule of the acromioclavicular joint. So this is the facet, then medial end and sternal end. This is the sternal end. The enlarged medial end has a saddle-shaped articular surface that articulates with the clavicular notch of manubrium sterni to form sternoclavicular joint. It provides attachment to the fibrous capsule, articular disc and interclavicular ligament. Now shaft. The shaft of the clavicle is divided into two parts, lateral one-third and medial two-third. The medial two-third of the shaft is convex forward and lateral one-third is concave forward. Lateral one-third is flattened from above downward and it has two surfaces, that is superior surface and inferior surface, and two borders, that is anterior border and posterior border. Now surfaces. So superior surface is subcutaneous between the attachment of deltoid and trapezius muscles, and the inferior surface it presents a conoid tubercle and a trapezoid ridge which provides attachment to conoid and trapezoid parts of coracoclavicular ligament respectively. So we have seen this conotubercle and trapezoid ridge, which provides attachment to the same parts, that is conoid and trapezoid part of coracoclavicular ligament. Now, conotubercle is located on the inferior surface near the posterior border at the junction of lateral 1/4 and medial 3/4 of the clavicle. The trapezoid ridge extends forward and laterally from the conoid tubercle borders. Anterior border, it is concave forward and gives origin to the deltoid muscle. A small tubercle called the deltoid tubercle may be present on this border. Posterior border is convex backward and provides insertion to the trapezius muscle. Medial 2/3. So now we have completed the lateral 1/3. Now let's see medial 2/3. So these borders of anterior and posterior, the deltoid and posterior, which has trapezoid muscle, are attached in the lateral 1/3. Now let's see all about the medial 2/3 of the shaft. It is cylindrical in shape and presents four surfaces: anterior, posterior, superior and inferior. Here there is no borders. So anterior surface is convex forward and gives origin to the clavicular head of pectoralis major muscle. Posterior surface is concave backwards and gives origin to sternohyoid muscle near its medial end. The lateral part of this surface forms the anterior border of cervicoaxillary canal and is related to the following structures. So the posterior surface firstly gives origin to sternohyoid muscle medially, and the lateral part of this this surface forms the anterior border of coracoaxillary canal. The canal formed cervicoaxillary canal between the neck and the axilla. So the canal contains the following structures: trunks of brachial plexus, which we will learn ahead. Then second is the third part of subclavian artery, superior surface. The clavicular head of sternocleidomastoid muscle originates from the medial half of this surface. Inferior surface presents the following features. First, costoclavicular ligament is attached to an oval impression in the medial end. Subclavius muscle is inserted in the subclavian groove on this surface. Clavipectoral fascia is attached to the margin of the subclavian groove, and nutrient foramen of the clavicle is located on the lateral end of subclavian groove. Now let's see figure 2.3. So this is anterior, posterior, lateral and medial side of this particular diagram. So anteriorly in the medial surface, superiorly we have pectoralis major, capsule of sternoclavicular joint and sternocleidomastoid, and laterally we have trapezius and deltoid insertion, and also the capsule of acromioclavicular joint. And in figure B we have anterior, this is posterior, medial and lateral. So anteriorly again the pectoralis major, capsule of sternoclavicular joint, articular facet for manubrium sterni, costoclavicular ligament, subclavius insertion, which is in the inferior view. This is the inferior view. So in the subclavian groove, in the conoid tubercle there is conoid part and trapezoid part of coracoclavicular ligament. Insertion of trapezius origin of deltoid. So note that all the origin are colored red and insertion are colored blue, and green refers ligament. This is the generalized rule. Now, muscles and ligament attached to the clavicle are: muscles are pectoralis major, sternocleidomastoid, clavicular head, then deltoid, trapezius, subclavius, and ligaments are coracoclavicular, costoclavicular, and interclavicular ligament. Now, let's see the clinical correlation, which is important. Fracture of clavicle. The clavicle is the most commonly fractured bone in the body. It commonly fractures at the junction of its lateral 1/3 and medial 2/3 due to blows to the shoulder or indirect force, usually as a result of strong impact on the hand or shoulder. When person falls on the outstretched hand or the shoulder, when the fractures occurs, the lateral fragment is displaced downwards by the weight of the upper limb because the trapezius alone is unable to support the weight of the upper limb. In addition, the lateral fragment is drawn medially by shoulder adductors, namely teres major, etc. The medial fragment is slightly elevated by sternocleidomastoid muscle. The characteristic clinical picture of the patient with fractured clavicle is that of a man or woman supporting his sagging or hanging upper limb with the opposite hand. The fracture at the junction of the lateral 1/3 and medial 2/3 occurs because this is the weakest site. The two curvature of the clavicle meet at this site. The transmission of force due to impact from scapula to the clavicle occur at this site through coracoclavicular ligament. The clavicle is absent in animal in which the upper limb are used only for walking and weight transmission, not for grasping, such as horse. So it is a peculiar feature of humans because grasping is not performed by primitive animals. One of the two primary center of the clavicle is regarded as the precoracoid element of reptilian shoulder girdle. So this is how the fractured clavicle appears. The sternocleidomastoid pull it upwards, so the medial 2/3 is pulled upwards, whereas due to the weight of this limb, this lateral 1/3 is put below, and the adductor, the teres major, pulls it medially. So this is how it appears. Now, ossification of the clavicle. So we have seen in the peculiar features that it has two primary centers, sternal end has one secondary center, and acromial end has another secondary center for ossification. The acromial center is occasional ossification. The ossification of the clavicle is membranocartilaginous, which we have seen just now in the figure. Whole of it ossifies in the membrane except for its medial end that ossifies in the cartilage. The clavicle begins to ossify before any other bone in the body. It ossifies by 4 ossification centers, 2 primary center for ossification and 2 secondary centers, one for each end. The site of appearance, time of appearance, and time of fusion of various centers is given in the table. Here it is given. Ossification centers of the clavicle. Site of appearance. Two primary centers, medial and lateral, in the shaft. Time of appearance is 5 to 7 weeks of intrauterine life, and time of fusion is 45th day of intrauterine life. Secondary center at sternal end appears at 19 to 20 years, 2 years earlier in females, and fuses at 25th year. Secondary center at the acromial end, which is occasional, appears at the 20th year and fuses immediately. Now let's see growing end of the clavicle. The sternal end of the clavicle is the growing end. So the clavicle grows medially because epiphysis at this end appears at the age of 19 to 20 years and unite with the shaft at the age of 25 years. In the last of all epiphyses in the body to fuse with the shaft. The radiological appearance of this epiphysis in female confirms their bone age for the legal consents to marriage. Last clinical correlation: congenital anomalies, clavicular dystosis. Clavicular dystosis, it is a clinical condition in which the medial and lateral parts of the clavicle remain separate due to non-union of two primary centers of ossification. And second is cleidocranial dystosis. It is a clinical condition characterized by partial or complete absence of clavicular association with the defective ossification of the skull bone. So that's all. Thank you.